Hello and welcome to our new topic about a group of very powerful drugs. We will explore opioid analgesics and antagonists, focusing on their mechanisms, pharmacokinetics, clinical applications, and safety concerns. These drugs remain central to pain management, yet they also carry significant risks, making a deep understanding essential for all clinicians. Let's start. The learning objectives are shown. Please take a look. In this session, you will understand how opioids work at the receptor level, how selective different agents are, and what their major adverse effects look like clinically. Finally, we will review the opioid antagonists and learn how they reverse toxicity and support withdrawal programs. Very often, inflammation, pain and fever go hand in hand as part of the pathogenesis of a disease. Hence we need drugs with anti-inflammatory, analgesic and antipyretic effects in many conditions, to reduce inflammation, pain and fever. The non-steroidal anti-inflammatory drugs are the only example that can reduce all three. Other drugs do it partially. For example, the glucocorticoids target inflammatory pathways only, while acetaminophen or paracetamol is good to relieve pain and fever. When we think about pain management, opioids, tramadol and nefapam sit within a broader landscape of pure analgesic drugs. Tramadol and nefapam occupy a space between traditional analgesics and centrally acting drugs. Understanding this landscape helps us identify when an opioid is appropriate and when alternative agents may be safer. Pain perception involves a complex ascending or sensory cascade that includes processes like transduction, transmission, modulation, and perception. Different drug classes act at different points in this pathway. Local anesthetics block transmission in peripheral nerves. NSAIDs reduce peripheral sensitization by suppressing prostaglandins, and opioids act both centrally and peripherally to modulate perception and emotional response to pain. This understanding explains why certain drugs are preferred in specific conditions to relieve pain, and combining drug classes can yield superior analgesia. All opioid drugs originate historically from the opium poppy, Papaver somniferum. The latex obtained from its seed pod contains multiple alkaloids, of which morphine is the principal natural compound. Because of its high abuse potential, cultivation is globally restricted, and its historical role in conflicts like the Opium Wars imposed by British Empire and France on China to let them sell opium in China and reflects its addictive power and cultural impact. Unfortunately, China lost the wars leading to their occupation of Hong Kong till year 1997. Thus, Western powers remained the driving force behind illicit drug cultivation and trade, making their countries rich and leading to widespread addiction and economic exploitation in other countries. Opioids primarily exert their analgesic effects by engaging the descending inhibitory pathways, from the periaqueductal grade to the rostral ventral medulla and down to the spinal cord. Activation of mu receptors enhances descending inhibition and suppresses nociceptive neurotransmitter release, reducing pain intensity and its emotional impact. We categorize opioids into natural alkaloids like morphine and codeine, semi-synthetic derivatives like heroin and falcodeine, and fully synthetic agents such as fentanyl, meperidine, and methadone. Mixed agonist antagonists, such as buprenorphine and nalbuphine, show agonist activity at some receptors and antagonistic activity at others, giving them distinctive clinical roles, particularly in dependence management. Opioid receptors, mu, kappa and delta, are widely distributed throughout the CNS and GI tract. The mu receptor is primarily responsible for analgesia but also mediates respiratory depression, euphoria, and physical dependence. Kappa receptors contribute to spinal analgesia and dysphoria, whereas delta receptors play a role in modulating emotional response and may enhance analgesia. When an opioid binds to its receptor, it triggers a conformational change in the G protein-coupled receptor. This leads to inhibition of adenylyl cyclase, opening of potassium channels leading to hyperpolarization, and inhibition of calcium influx, which suppresses neurotransmitter release. The net result is decreased neuronal excitability and reduced transmission of pain signals. Opioids have a wide spectrum of adverse effects. Central effects include sedation, euphoria or dysphoria, and increased intracranial pressure. Respiratory depression is the most dangerous effect and the primary cause of opioid-related death. Cardiovascular effects include bradycardia and postural hypotension. GI effects, nausea, vomiting, constipation, and biliary spasm, are almost universal. Opioids also cause urinary retention, pruritus, and endocrine changes such as reduced uterine contractility. With repeated use, patients develop tolerance to many opioid effects, particularly analgesia and euphoria, requiring higher doses over time. However, tolerance to constipation and meiosis does not develop significantly, which is why these side effects persist even with chronic therapy. When opioid use stops abruptly, patients experience a characteristic withdrawal syndrome. Symptoms include lacrimation, rhinorrhea, gooseflesh, sweating, hyperthermia, hypertension, and severe GI upset. Psychologically, patients may develop agitation, dysphoria, anxiety, and insomnia. Although withdrawal is rarely life-threatening, it is intensely uncomfortable and drives continued drug use. Another phenomenon is opioid-induced hyperalgesia, where prolonged opioid exposure paradoxically sensitizes the nervous system, lowering the pain threshold. This creates a cycle where increasing doses worsen pain sensitivity, making clinical management complex. Tramadol is a weak mu receptor agonist but also inhibits the reuptake of serotonin and norepinephrine. This dual action makes it useful in neuropathic pain. However, because of its serotonergic effect, it carries the risk of serotonin syndrome and may precipitate seizures, especially at higher doses or when combined with other serotonergic agents. Tapentadol has a stronger mu receptor agonist effect and is a potent norepinephrine reuptake inhibitor. By enhancing alpha-2-mediated descending inhibition, it provides effective relief in neuropathic pain while maintaining opioid-like analgesic potency. Adverse effects resemble opioid toxicity but also include nausea and headache. Naloxone is the antidote of choice for acute opioid overdose. It rapidly displaces opioids from mu receptors, reversing respiratory depression within minutes. However, its short duration means repeated dosing may be required. Naltrexone, with a much longer duration, is used in withdrawal maintenance programs and for alcohol and nicotine dependence in combination with agents like bupropion. Methylnaltrexone and alvimipam are special as they do not cross the blood-brain barrier, meaning they relieve opioid-induced constipation without reversing central analgesia. They are valuable in chronic pain patients who require long-term opioids but struggle with refractory constipation. This poster summarizes various medications for treating opioid overdose, withdrawal and addiction. Note how opioid receptor agonists, antagonists and adrenergic agonists are useful in this regard. Take some time to explore it. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!